disorders of the facial nerve. Facial nerve is a mixed nerve having 10,000 neurons, 7,000 motor neurons and 3,000 sensory neurons. It is predominantly a motor nerve. It has three nuclei. One is motor nucleus, which lies in caudal pons. Next is superior salivatory nucleus that lies dorsal to the motor nucleus. And third one is nucleus of solitary tract that lies in the medulla. This picture shows different facial nerve nuclei. This is the motor nucleus, this is the superior salivatory nucleus, and this is the nucleus of the solitary tract. The superior aspect of motor nucleus has both crossed and uncrossed input. Therefore, in case of upper motor neuron lesions, only the lower part of the face on the contralateral side will be affected due to bilateral control to the upper facial muscles, frontalis and orbicularis oculi. The inferior aspect of the motor nucleus has contralateral input. So in case of lower motor neuron lesions, both upper and lower facial weakness occurs on the same side of lesion. This is very important. You can see here, this is the upper motor neuron lesion, where there will be involvement of one side only, that is the lower portion on the opposite side. Whereas in lower motor neuron lesions, there will be affection of one part of the face, because as you know, the lower portion is supplied by the contralateral side only. How to differentiate between upper motor neuron and lower motor neuron facial paralysis? In case of upper motor neuron lesion, there will be bilateral forehead wrinkling, bilateral eye closure, absence of nasolabial fold on the opposite side, and drooping of angle of mouth on the opposite side. Whereas in case of lower motor neuron facial paralysis, as we have already told, there will be affection of one side of face. So forehead wrinkling will be absent on the same side, eye closure will be absent on the same side, nasolabial fold will be absent on the same side, and drooping of angle of mouth will be towards the same side. Coming to facial nerve trunks, the facial nerve trunk has 5 fiber types. They are special visceral efferent, supplies nerve supply to muscles of facial expression, stapedius, stylohyoid, and posterior berry of diagnostic muscle. General visceral efferent supplies the lacrimal glands, nasal mucosa, sublingual and submandibular salivary glands. So salivary flow is important with general visceral efferent fibers. Special sensory fibers carry taste sensation from anterior throat of tongue. The somatic sensory fibers, they supply the external canal and the concha, small portion. And sometimes the visceral efferent fibers, they carry sensation from mucosa of the nose, pharynx and palate. With this idea, we'll go to course and parts of facial nerve. The facial nerve has intercranial portion starting from pons to the porus of the interartery meatus, meatal segment which lies in the interartery meatus, that is from the porus to fundus of the interartery meatus. Labyrinthine segment, the name signifies, lies above the labyrinth from the fallopian canal to the first genu. Tympanic segment from the first genu to the second genu, and the mastoid segment from the second genu to the sternemastoid foramen. So meatal, labyrinthine, tympanic and mastoid segments are the intratemporal segments of facial nerve, whereas extratemporal segment is when the facial nerve comes out from the sternemastoid foramen. Now we shall discuss in different facial nerve segments. Supranuclear segment, look, it lies in the cerebral cortex. The brainstem, motor nucleus and superior salivatory nucleus are present. The meatal segment extends from brainstem to the interartery canal. It's around 8 to 10 millimeters in length. The labyrinthine segment is located between the fundus of ISC to genicular ganglion, which is around 3 to 4 millimeter. And I want to stress here that the labyrinthine segment is the shortest and even the narrowest segment of the facial nerve. So it is more commonly affected during either facial nerve trauma or to chemical injury of facial nerve. The tympanic segment starts from genicular ganglion to the pyramidal eminence. It is around 8 to 11 millimeters in length. The mastoid segment starts from pyramidal eminence to the sternemastoid foramen, which is 10 to 14 millimeters in length. And the extratemporal segment, which is the longest segment, start from stalomastoid foramen to the pes anserinus. It is stressed here that facial nerve has the longest intratemporal course in the temporal bone. The intracranial portion, which extends from pons to the porus of eyes, is 25 mm in length. The intertemporal portion, meatal segment, in the interanterior meatus. Laminating segment is shortest, as already told, 4 mm. The narrowest segment around 0.68 mm. It extends from fallopian canal to the genicular ganglion, that is first genu. Branch given here is greater superficial pedicel nerve. It lacks anastomosing arterial cascades, therefore it is involved in nerve edema, in fracture temporal bone, and vascular compression, embolic phenomena, or low flow states. The tympanic segment, also called the horizontal segment, although it is not truly horizontal, this is 8 to 11 mm in length. It traverses from the genicular ganglion to the pyramidal process, that is second genu. It is commonly dehiscent congenitally, therefore it is damaged during surgery. The mastoid segment, also called as the vertical segment of facial nerve, is around 10 to 4 mm in length and starts from pyramid and ends in stalomastoid foramen. The second genu lies lateral and posterior to the pyramidal process. This is very important. Posterior and lateral to pyramidal process. The branches given here are nerve to stapedius, chorda tympani, posterior auricular nerve, and the muscular branches. Extracranial or extratemporal portion is the longest portion of the facial nerve, which is around 15 to 20 mm in length. It gives peripheral branches. They are temporal, zygomatic, buccal, marginal mandibular, and the cervical branch. These are the peripheral branches of facial nerve. What are surgical landmarks of the facial nerve? During surgery of facial nerve, this is very important to identify the surgical landmarks. Otherwise, there is high chance of damage to the facial nerve. Processus cochleariformis is a small bony protuberance from which the tensor tympani muscle turns 90 degrees to insert into the malleus. This lies around 1 mm inferior to the genicular ganglion. So if you find out the processus cochleariformis, you can find out the first genu of facial nerve. Second is the cog, which is bony ridge hanging from tegment tympani, which lies 1 mm above and posterior to the processus cochleariformis again. So if you find out the cog, then you can find out the first segment of facial nerve. You can find out the first genu of the facial nerve. 2 mm below the surface of incus lies the external genu. Therefore, you can also find out the position of facial nerve once you find out the surface of incus. The area where the surface of incus lies is called as fossa inclutis. It is also one of the landmarks for facial recess approach. Next is lateral semicervical canal. External genu of the facial nerve lies around 2 mm antero-inferomedially from the lateral semicervical canal. Therefore, it is also a very good landmark for the facial nerve. For your information, the dome of lateral semicervical canal is the medial boundary of the mastoid antrum also. Oval window is also an important landmark. Facial nerve lies 1 mm above the external. Oval window is the next landmark. External genu of the facial nerve lies around 1 mm above the oval window. Therefore, if you find out the oval window, you will be finding out the location of facial nerve, which is very important during either stapes surgery or during mastoid surgery. Inferior edge of the posterior semicervical canal is also important. The mastoid segment of facial nerve lies around 2 mm anterior and lateral to the inferior edge of the posterior semicervical canal. The mastoid segment of facial nerve lies around 5 to 8 mm medial to tympanomastoid suture. The diagnostic ridge in the mastoid tip leads to mastoid segment of facial nerve towards its anteromedially. You can see the facial canal here. This is the facial canal, and this is the processus cochleariformis. This is the bone, which is near to canal of the tensor tympani. This is the oval window. the facial canal lies above the oval window. This is pyramid, the facial nerve lies posterior to the pyramid. Okay, these are the good landmarks for the facial nerve during your surgery. Here same thing, this is the oval window. The facial nerve lies above the oval window. This is the lateral semicircular canal. The facial nerve lies anterior-inferiorly medially towards the anterior-inferior medial to the lateral semicircular canal. Okay, this is the process cochleariformis here, and the facial nerve lies above it. And this is the pyramid, and facial nerve lies posterior to the pyramid. And this is steromastoid foramen. Facial nerve exits out through steromastoid foramen. How to classify the facial nerve injuries? There are two basic classification systems of facial nerve injury. One is Serine classification, which was devised in 1943, and divided the facial nerve injury into neuropraxia, axonotmesis, and neurodemesis. And Sundaran classification is more commonly accepted classification. It has 5 grades: first degree, second degree, third degree, fourth and fifth degrees. First degree is neuropraxia, like Serine's classification. There is complete recovery of facial nerve if the patient is treated in time. Second degree is axonotmesis. The axons will be damaged, whereas there is usually complete recovery from the facial nerve. Recovery can be graded into House-Brackman classification, which is beyond the scope of today's class. Third degree is neurodemesis, when the neurons also will be affected and there will be incomplete recovery. And fourth and fifth degrees, there will be again incomplete recovery, and the fifth degree there might be synkinesis due to complete transection of facial nerve. Now the classification in gist: neuropraxia, Serine's classification, and Sundaram classification type 1, axonotmesis 2, and neurodemesis 5. This is the picture showing Valerian degeneration. In case of simple neuropraxia, there will be conduction block, so there will be complete recovery. In case of axonotmesis, the axons will be damaged. Okay, you can see the axons here which are being damaged partly, so there will be axonal discontinuity. In case of third degree Sundaram classification, there will be axon plus endolymph disruptions. This is like neurodemesis. In fourth degree, there will be perineural rupture and physical disruptions. This is almost incomplete paralysis. And in the fifth type, there will be complete nerve trunk discontinuity, which leads to synkinesis or mass movement of the muscles. Coming to different causes of otogenic facial paralysis, they can be classified as traumatic facial paralysis. Fracture of temporal bone might be longitudinal or transverse fracture, penetrating injury to middle ear or mastoid, facial injuries, and iatrogenic injuries during surgery. Infective conditions: herpes zoster oticus, also called as Ramsay-Hunt syndrome, acute suppurative otitis media. Etiquental type of chronic suppurative otitis media is the common condition that leads to facial paralysis and sometimes malignant otitis externa. Neoplastic, glomus tumors, schwannoma, middle ear malignancies, and metastatic carcinomas all can damage the facial nerve. Bell's palsy is one of the idiopathic conditions that might lead to unilateral lower motor neuron facial paralysis. How to diagnose the facial nerve paralysis? We can diagnose facial nerve paralysis by topo-diagnostic tests. This gives the idea of the site of damage. They are hearing and balance test, Servos Test, stapedial reflex test, submandibular salivary flow, and the test. Electro diagnostic tests, they help to identify the amount of facial nerve injury in comparison to opposite side. They can be again classified as maximal nerve stimulation, electromyography, and evoked electromyography, that is electroneuronography. Then radiological tests like CT scan, MRI, immunological tests like ANA, RA factor, VDRL, and Monspot test, ESR, and bone marrow to identify leukemia or lymphoma if present. What are topo-diagnostic tests? They are the tests which help us to determine the anatomical level of peripheral lesion. The principle lies in the fact that the lesions which are distal to the site of particular branch of facial nerve will impair the function of the certain branch. Like hearing and balance, the effects would lie at the entortic canal. Servos test is quantitative evaluation of tear production. When the lesion is at or proximal to genicular ganglion, there might be defect on the Servos test. Thermostasis is supposed to be significant when unilateral wetness is reduced by more than 30% of the total amount of both eyes after 5 minutes, or when the bilateral tearing is reduced to less than 25 mm after a 5-minute period. Stability reflex test. When there is absence of stability reflex, we suppose that the region is proximal to the stability knob. In case of subinverse library flow test and test also helps to identify the lesion of facial knob. Coming to electrodiagnostic test, they are knob excitable test. The technique is using a stimulating electrode over the terminal ramifications of the facial knob. Increase the current in milliamperes until movement is seen in the appropriate muscle group. The normal values from the unaffected side are compared to the side of paralysis, and a difference of 3.5 milliamperes or more signifies the unfavorable prognosis. This is very important. Coming to electromyography. Electromyography has prognostic value in traumatic facial nerve injury. The principle behind that is a denervated muscle produces spontaneous electrical potentials or fibrillations after 14 to 21 days. Therefore, presence of voluntary motor unit action potential signifies the chance of incomplete paralysis. So, early presence of BAMP around 10 to 14 days give a better clinical outcome, suggesting to no need for surgical decompression. The next is electromyography or evoked electromyography. The implication here is that the difference in amplitude of the potentials of intact and the involved side of the face correlate well with the percentage of degenerated motor fibers, that is, denervation. The disadvantage is that it's a quantitative analysis of amount of degeneration, how much amount has been degenerated, and the disadvantage of that are amplitudes are 24 to 48 hours delayed representations of actual events occurring at the site of lesion. That is very important. Clinical applications of electrodiagnostics are that facial nerve subjected to traumatic injuries of a magnitude requiring surgical repair undergo 90% degeneration within 6 days of injury. Therefore, when there is 90% degeneration by 6 days of injury, patient has to undergo surgery. In case of Bell's palsy, a poor prognosis can be anticipated in patients reaching 95% or more degeneration within 14 days of onset of paralysis. So, early paralysis having around 95% or more degeneration by 2 weeks carries a poor prognosis. With this idea, we'll move to common disorders. Bell's palsy is very important from examination point of view, both practicals and theory. It is the commonest cause of lower motor neuron facial palsy. Around 80% of all the causes of lower motor neuron facial paralysis are due to Bell's palsy. It is defined as acute, idiopathic, unilateral, peripheral lower motor neuron facial paralysis with viral prodrome or sometimes vascular cause. There is no sex predilection or no side predilection. Common age is 5th to 6th decade. There is 10% of family history, and the pathophysiology commonly suspected is nerve swelling within the facial canal. What are the clinical features? The most common clinical feature is unilateral lower motor neuron facial paralysis, which progresses to maximal deficit over 3 to 7 hours. Therefore, when the patient gets admitted by 3 to 72 hours, then there is very high chance of recovery. Pain occurs in 50% of individuals, which will be usually near the menstrual process or in the post-auricular area. There might be excess tearing, around 33%, hyperacusis or dysgeusia. There will be weakness of all branches of the nerve, upper and lower, and in unilateral condition. Degree will be from partial to complete paralysis. Affected side will be flat and expressionless. Intact side will be twisted, and there will be palpable fissure widening and eyes lunar close. Stapedial dysfunction, around 33% of people leading to hyperacusis. Lacrimation will be mildly affected in some patients. Test, there will be no clinically significant changes in most of the patients because the paratympani supplies only anterior to third of the tongue, one side. Therefore, around 66% of tongue will have supply from the opposite. Therefore, there will be not much of taste sensation or not much of taste disturbance in most patients. Sensory loss shall be mild or none. It may be present on face or tongue or on the side of paralysis, either on right or left. We already told this will be unilateral facial nerve paralysis. This is the facial nerve paralysis in here. This is the affected side and the non-affected side, which is pulling the mouth up. Again, this side is the non-affected side and this is the affected side. You can see the expressionless face with drooping of angle of mouth towards the left side in this patient. What is the natural history of Bell's palsy? Bell's palsy might present by 3 hours to 3 days. It might be complete or incomplete. Recovery begins within 3 weeks. There shall be full recovery by 6 months in around 84% of the individuals. But in case of herpes zoster oticus, there will be only 60% full recovery. Recurrence is commoner in Bell's palsy, which is around 12%, whereas in herpes zoster oticus, recurrence is less, around 150%. Decrease in response to electrical testing peaks in 5 to 10 days in case of Bell's palsy early, but in case of herpes zoster oticus, it peaks by 10 to 14 days. Herpes zoster oticus or Ramsey-Hunt syndrome is defined as acute lower motor neuron facial paralysis caused due to herpes zoster virus infection of the genital ganglion of the facial nerve. It usually presents as the viral prodrome and there will be severe pain in and around the ear, as you can see here, severe painful area, and there will be vesicles and pinna, face, neck, or an oral cavity. 100% of the patients, the vesicles lie in the pinna. So this is the pinna, these are the vesicles. Then face, this is the face, the neck, and oral cavity. The patient also might develop sensory loss or vertigo in 40% of the conditions. How to treat a case of facial paralysis? For all cases of facial paralysis, we have to reassure the patient, we have to give physical therapy, psychosomatic therapy, physiotherapy of the face, and eye care. How to do eye care? Important thing in eye care is corneal protection. Antibiotics eye drops are given at antibiotic eye drops like ciprofloxacin, 2 drops in the eye 3 times a day. Antibiotic ointment at night time to avoid exposure keratitis or foreign bodies entering the eyes. Natural tears, isotonic saline, and methylcellulose drops are important for muscle relaxation. Natural tears, isotonic saline, and methylcellulose drops are important to reduce the dryness of the eyes. Strips of skin tape to help close the eyes can be given, and patient might be done temporary patching and tarsorrhaphy. The patient has to give more comfort. So patient is patient is again counseled, and it has to be told that patient should be all right. For Bell's palsy, there is some benefit with steroid therapy. Prednisone given as 1 mg per kg per day, around 6 to 8 mg, to begin 24 to 48 hours after onset, and given for a week, then decrease gradually over the second week. This is very important. For Bell's palsy, there is a role of steroids. Steroids help to reduce residual paralysis, and they also improve recovery. Antibiotic agents like acyclovir or phencyclovir can be given. Next, for herpes zoster oticus or Ramsey-Hunt syndrome, antiviral agents acyclovir 800 mg 5 times a day for 7 days, or for best results, treatment should be started within 3 days after symptoms appear. Therefore, the patient has to come to hospital by less than 3 days. Steroids also can be given in low doses. And carbamazepine to decrease post-herpetic neuralgia, 20 to 60 mg 3 times a day is very much painful condition. Vaccines like varicella vaccine and Zostavax, which are helpful in preventing viral reactivation only. What are the other modalities of treatment of facial paralysis? Cosmetic restoration or static procedures like facial slings from fasciolata, tarsorrhaphy, gold weight prosthesis, and temporary muscle transposition as well as eyelid springs or implants are important. They are just static procedures, they are not dynamic. So other modalities like cosmetic restoration, also got static procedures like facial slings made on fasciolata, tarsorrhaphy, gold weight prosthesis in the upper lids, temporary muscle transposition as well as eyelid springs or implants are sometimes important. So they are all static procedures, not dynamic ones. They have just a one-way function. Coming to surgical treatment of facial paralysis, this is usually dynamic. We can do facial decompression till the meatal foramen, starting from the Philippine canal. Nerve repair or neurography can be performed with end-to-end anastomosis when the paralyzed segment is small, or cable grafting with the sural or the greater auricular nerve when the nerve defect is big. Nerve transposition, facial hypoglossal anastomosis has been performed time by time. Then microneurovascular muscle flaps, they are under study. Now what should be the treatment protocol? When the patient presents within 3 weeks, the nerve decompression or repair is best one. When the patient presents from 3 weeks to 2 years, we can do nerve repair or nerve transposition. For more than 2 years of the fibrillations in electromyography, go for nerve repair or nerve transposition. For more than 2 years with electrical silence in electromyography, so no movement, then go for muscle transposition or eyelid implant, static procedure or facial sling. There the static procedures have to be done when the patient presents after 2 years. Thank you very much.